Well, one thing, oftentimes when people come to my office, and it's early in the course of the illness, and people have swollen joints and tender joints, and it hasn't been around for more than a few weeks, you kind of hope in a way that it's an infection of some sort that's easily diagnosed and treated and it goes away. Many viral illnesses produce some viral like arthritic symptoms or joint pain, and they typically will disappear after a few weeks. One of, for example, is mononucleosis. It'll create an arthritic set of symptoms along with everything else that it does, and it's temporary, and it might even produce a positive nuclear antibody, and people say, oh, this patient might have lupus, but in fact it's probably mononucleosis, and it will get better. And so one of the best things we do early on in the course of illness is, take a look at the overall picture, but we always want to have in the back of our mind, could this be an infection? So I thought for once in a long time I'd talk about infections and arthritis, because that's the most important thing we do when we first see a patient, is to make sure we don't miss this, because these are frequently very treatable, diagnosable if you do the proper thing. That's why I tap joints and make sure we take some fluid and send it for analysis, do cultures if we think that might be the case. But then other things, and I'll go through some of these things here this evening so you can help kind of get a little bit of a mindset of why we do some of these early tests. Everybody says, well, do I have this, arthritis or that? But this is the first and foremost, my job to make sure you don't have an infection causing your symptoms. So the answer is yes, definitely. There's no question that infections cause arthritis. And we still think we might find an infection that produces rheumatoid arthritis, but we've never discovered the exact organism. For example, Epstein-Barr virus has been often thought to be a potential cause of rheumatoid arthritis, but that's never been proven. Just about as many people with rheumatoid arthritis don't have Epstein-Barr virus antibodies in their bloodstream as those who do. So it's never been proven, and they've never been able to really isolate the organism. But swollen joints happen for a number of reasons, and this is kind of a quick overview of what we think about. Infections first. Could it be trauma, internal derangement, problem with the joint, a degenerative process like osteoarthritis and other metabolic disorders. Crystalline arthritic things, that's where the joint flow is very helpful. We find the crystals in there and we can differentiate whether it's gout or pseudo-gout. Autoimmune disorders are things you know about, rheumatoid, lupus, ankylosing spondylitis, psoriatic arthritis. And once in a while, malignancies, particularly leukemias, can have articular symptoms. And of course, solid tumors, particularly in children, we see things like Wilms tumors in joints, for example. Fortunately, I've only seen one of those in my experience. It was a 23-year-old woman from not too far away from here. So the question about infections and how does it trigger arthritis? Well, there's two ways. First of all, it's either an active infection that you can demonstrate in the joint, or the title of my talk suggested reactive arthritis was an interesting topic, and this is all about the gut and the genitourinary system and what happens there, and then it triggers arthritis somewhere else, and we'll get to that toward the end. So it's either an active infection in the joint itself, or there was an infection somewhere else that triggered this response in the person to create an arthritic condition that's not only within the joints, but other manifestations of that disease will be clear when I get done with my talk. So we call active infection within the joint a septic joint. Sepsis means infection of the blood. Septic means infection somewhere, but a septic joint is an infected joint. So we tap the joint and we look what's in there. We tap the joint when somebody's got a Band-Aid over my needle spot. And on the right, we put it on the microscope. They do a special stain called gram stain, and this particular organism is a gram-positive coccus. They're little round things. They're usually in clusters or in chains. You can see both formations, but that's Staph aureus, that's Staphylococcus infection. That's the most common. We see streptococcal, probably the most second common, and then there are some other things like Neisseria gonorrhea, for example, will cause swollen joints. But that organism is so hard to culture that you don't typically find it in the joint, but you do find it when you culture areas where that organism might be in the genital area, in our because that's a venereal disorder. Oops. So for the most part, most of the time, septic joints appear as one in a single joint. That's the most common. We do see on rare occasions polyarticular, multiple joints infect at the same time, but most of the time it's a single joint. If you see multiple joints, it's less apt to be infectious, but nevertheless we want to tap the joint, culture the joint, look at the fluid carefully. And it's most often in the big joints. It's really rare to see an infected small joint, isolated small joint, unless it's been traumatized or poked with something or other that introduced infection, like a thorn. We see rose thorn arthritis and things of that nature on occasion that are triggered by a puncture of the joint itself. Or sometimes if there's an inflammation of the skin, a skin infection, a cellulitis near that joint, that cellulitis might potentially move into the joint. And once in a while, if there's a fracture and the fracture site happens to open up to the skin and it's near the joint, that might create a point of entry for the germs to enter the joint and secondarily get a septic joint due to a fracture in the area. Most of the time, infected joints come from the organism entering the bloodstream and going to a joint that's oftentimes predisposed. The most common forms of blood-borne arthritis are meningitis, and we see this not infrequently in children, and yet really young children. Pre-existingly damaged joints for some reason are more susceptible. A rheumatoid arthritic joint, a joint with osteoarthritis, and any other kind of inflammatory arthritis, psoriatic arthritis, doesn't matter, but a joint that's been damaged to some other form of arthritis seems to be more susceptible to an infection. Now, people that are immunosuppressed, people that have immunosuppression for kidney transplants and then they get septic, they get a joint infection, for example. Or if you happen to have immune deficiency on the basis of HIV or hereditary forms of immunoglobulin deficiencies are rare, but they do occur. Those individuals are a bit more susceptible to infection. And of course, our people that use IV street drugs are not uncommonly affected. And they'll show up in the emergency room with a swollen joint here and there. And interestingly enough, a lot of those turn out to be an unusual organism known as Pseudomonas, which is more often found in bowel infections when people have, or people that have had ongoing antibiotics, that organism has a chance to wake up and be more aggressive in the body. Now, the other less common problems are endocarditis, which is a heart valve infection. And I'll remember some years ago when I was resident and I was moonlighting in a small emergency room on the weekend, trying to pay for that stereo set that I just had to have, of course, back in those days. But some young man showed up with a swollen joint, and I listened to his heart, and he had a rather significant heart murmur, and I tapped the joint, cultured the joint, and shipped him off to the clinic, which was up the road 30 miles, and this young man had staphylococcal endocarditis, and it just happened to show up at the same moment in the emergency room. But there's a wide number of musculoskeletal symptoms that accompany valvular endocarditis, and they can be anywhere from just achy joints to muscle pain to swollen joints. It can be multiple joints. It can be these people do in fact have a lot of musculoskeletal symptoms associated with their valve infection. Another bad thing about valve infections, those organisms can break loose and fly off to other areas and cause stroke-like events, and infections in the skin happen on occasion. Most of them are staph or strep, much the same organisms. Sometimes E. coli, particularly when people have chronic urinary issues and become septic, they can deposit in the joint. And the venereal infections that we mentioned earlier, gonorrhea, for example. There is a syphilitic arthritis that does occur in syphilis. We haven't seen it with any of the newer organisms that we're immunizing our children with. that causes the papillovirus that causes cervical cancer, that sort of thing. That doesn't seem to cause arthritis, fortunately. These are risk factors. People that are immunosuppressed, people with autoimmune disease, particularly rheumatoid arthritis, diabetics, elderly people who have less maintained immune systems. Previous prosthetic joints are prone to infections. That's why it's important to have antibiotics before you have major dental procedures or colonoscopies, that sort of thing. Recent joint surgery has a risk for a joint infection, of course. They're rare, fortunately. Again, cellulitis in the region of the joint, as I mentioned, and the IV abuse. And for some people that are serious alcoholics seem to have a tendency to have infected joints as well. So we do a thing called arthrostatesis. That's the fancy word for tapping the joint, putting a needle in there, drawing out the fluid. And that's kind of the name of that's the best rheumatologist tool I have. My analysis of the joint fluid is the window into the bank vault. If we don't open the door, then we'll never get the money out, so we have to put a needle in there, take out the key clue, and figure out what's going on. Typically, the cell counts are quite high, although some counts aren't extremely high. The normal synovial fluid, I'll show you a slide about that, but there's a relatively small number of white blood cells. But in inflammatory forms of arthritis, it's elevated. And in infected joints, it's quite elevated. Again, we make sure there aren't crystals. We look for culture positivity and gram stains, which I showed you earlier. This is a case that I saw not too many months ago. A woman who's about 60 years of age. She had a rash, fever, a swollen ankle and a knee, no heart murmurs. Her blood and urine cultures were negative. All the autoimmune markers were negative, but the inflammatory markers were elevated. Her uric acid was normal. She had a synovial fluid analysis which showed 70,000 white cells. That's very high. Normal is less than 500. And most rheumatoid patients that I see have counts between 5,000 and 20 or 30,000. So a 70,000 white count gets your attention. But there have been positive cultures in people that have cell counts as low as 10,000. So the number doesn't dissuade you from culturing that fluid just to make sure. And we found these, once again, that same picture I showed you earlier, the positive bacteria in chains and grape-like bunches known as staphylococcus. So that's how you make that diagnosis. It seems pretty straightforward, but it's one of those things that people need to get, when something like this happens, you get it done quickly and get the treatment started quickly. But I've seen people go in the hospital, for example, a gentleman I saw in the hospital a year or two ago he had this huge swollen arm. It looked like cellulitis from here all the way down to his fingertips. Red, hot, inflamed everywhere. Well, they did blood cultures and urine cultures, and they had him on antibiotics for 3 days, and he wasn't getting better. So I went over and I had a careful look at him. He actually had swollen joints. We tapped those, and we found actually crystals associated with calcium pyrophosphate disease, that so-called pseudogout. But that stuff causes fever and a cellulitis picture. People, it's hard to believe, but that is amazingly inflamed piece of tissue, and the joints are inflamed, and we find those crystals. When you take the fluid out of a badly infected joint, it looks like that. It's thick and it's purulent. It's basically good old-fashioned bad stuff. And here's the difference. What's that?
Does it really smell?
I don't know that I've ever taken a lot of time to smell it. It would, yes, it would. It would be, yeah, it wouldn't smell good. I usually have it inside a syringe, so I don't really. But here's what the joint fluid numbers look like. Normal is clear color fluid. I never see that. I've never drawn clear color fluid out of any joints in my life. That's a normal joint. The non-inflammatory cell counts range from 200 to about 2,000. It can be a little bit yellow. That's called xanthochromia, and it's usually nice and thick. If it's inflammatory, it's very cloudy. It's yellow, and the viscosity is low. If you drip it out of the end of the syringe, in the old days we just do this, but now with all the OSHA rules we can't expose anybody to anything. But if you drip it out of the end of the syringe, it's real thin, and it just drops out of there. But the viscous fluid makes a longer string. But in the septic joint, big numbers, and they're mostly granulocytic white cells. Those are the ones that gobble up germs. I thought I'd talk a little bit about Lyme disease, because this is, in a way, a reactive kind of arthritis as well. This is actually was put together by a rheumatologist, discovered this particular diagnosis back in 1977. It was originally described, and it was discovered in Lyme, Connecticut, hence the name Lyme arthritis. And it's a little bacteria known as a spirochete. It's a little spiral-shaped little germ under the microscope, hence the name spirochete. And it's got a nice fancy name that I have a hard time pronouncing. In the United States, this is the most common organisms, Borrelia burgdorferi, REI. In Europe, they have a couple other spirochetes that create the same illness over there. Different types of, it's the same germ with a slight variability. But it creates the same diagnosis initially over there. Slight variation, but very similar. But it's interesting, even though we think it's interesting, I went to med school and I was practically through my residency before this diagnosis even came along. And so new things are discovered from time to time that really, we can do something about, because this is a treatable disease. Okay. I'm stuck here. This is the little fella. It's a black-legged tick, which is also most commonly known as a deer tick, because the deer is a common carrier of this organism. And it looked pretty big on there, but that's a small tick. That's the adult male, and it's, or adult female rather. It's got the little orange bottom as opposed to the adult male. It's a little bit smaller, and there's the nymph phase and the larva phase. And they're in the small animals in the forest, like in the small field mice and whatever, and then they get transferred to the larger animals like the deer typically. Although they can be found on a horse on occasion. So if you have horses running through the woods in the right part of the country, that's a possible carrier. And then it's transferred by the tick to the human when you're bitten with this little tick. They're quite small, oftentimes not recognized. Even if the tick is infected with this organism, it really needs to be on your body for a while. An hour or two frequently doesn't long enough. It usually has to be on your body at least 24 hours before it becomes an infection. But you can see how small it is compared to a dime. It's about like a pencil dot. If you take your ink pen and put it on the paper, that's how big it is. And it's not everywhere. There's a species out in the west coast called the western black-legged tick, and on the east it's called the black-legged tick. You can see where it is. And it's really not been recognized in Nebraska. The people that I've seen with this disease typically have picked it up somewhere else. So put on your off and your high boots, and if you go through the woods, and especially on the northeast coast, make sure you take a good shower and check yourself carefully you don't have a tick. The symptoms in the beginning are kind of nonspecific. Lots of things cause fatigue, loss of appetite, headaches, stiff neck, muscle aches, joint pain, swollen lymph nodes, and fever. That could be a lot of things. I think it's not very specific. The interesting thing is, initially it causes all those sort of symptoms, but it may cause a number of things that you wouldn't expect after it's been there a while and it's been in your body and it's unrecognized, untreated. You can have inflammation in the nervous system. It can cause a type of meningitis. It can cause nerve palsies, and it's not unusual for these people to have, for example, like a Bell's palsy in the face. It can cause a nerve symptom, and a weakness in a nerve root to your leg or arm called radiculopathy, or it can cause a widespread nerve damage called peripheral neuropathy, which is associated with numbness, burning, and weakness. It can cause inflammation of the heart and the heart surface, called carditis. Some individuals can have heart block associated with it. Rarely the eye's inflamed, maybe 10% of that group that make it through that are not recognized. And it can cause inflammation internally within the eye, iritis, uveitis, retinitis, optic nerve damage can occur. And last but not least, my little corner of the world, the arthritis. Most of the time it's monoarticular. They're almost always in the knee for some reason, once in a while somewhere else. But almost once this disease has been on board, about 60% of the people that have Lyme disease do have a swollen joint. They have a strong tendency to have this early on, this particular rash I'll show you called erythema migrans. Interesting, it's a red lesion. There's the signal lesion where the bite is, but then other lesions show up elsewhere, and we'll show you some pictures of that. There's a specific way to test for it. There's a screening test called ELISA, E-L-I-S-A. That's the screening test, and if you find that to be positive, or if you're really suspicious, you do a thing called a Western blot. And that takes a whole lot of different proteins and analyze them, and you have to have 5 of those positive. And certain numbers are more important than other numbers. There's a whole long list. I didn't want to get into all that detail, but that's the definitive test for it. This is you don't culture this organism in the joint or the blood very often. It's very difficult to culture. There are some things that happen in this joint fluid that are a little unusual. You can see an increased number of what's called eosinophilic white blood cells. Usually eosinophilia means you have an allergy reaction or a parasitic infection. Well, that's sort of what this is, a little bit of a bacterial parasite in a sense. And it will cause an increased eosinophil count in the synovial fluid, which is something, we can keep in mind if we're thinking about it. And there's also a very specific protein test called PCR that you can take the joint fluid and run this test. And it's not a common clinical thing we do very often. I've only had a high suspicion on one patient, and I sent the fluid off to the Mayo Clinic to be tested for this particular protein because I was quite suspicious the person had it, and yet everything didn't quite fit. But it's not a common test. And then, where do we go here? Thought I'd show you these lesions. This is a tick bite. You can see the round nature of it, the erythematous border, the central pallor, and it's kind of reddish brown, and it's raised. And there's a little bit of tissue damage here. That's what necrotic center means. That's the signal lesion. That's the target lesion. Here's a lesion on an abdomen. This one isn't quite as pale in the middle, very confluent, very brownish red. These lesions are almost always on the trunk or the proximal portion of the thigh. We rarely see them out on the limbs very far. This is a person with Lyme disease, and again, the central pallor, the red erythematous, a large landed trunk, or the upper thigh. And this person had associated Bell's palsy and had a positive test in his blood for this disease. There's a person with a target lesion on the top, on the abdomen. The secondary lesion is on his thigh. The original lesion's up there on his abdomen. The new red thing on his thigh is called a secondary lesion. And this person on the bottom has multiple lesions, more disseminated disease. And there's someone who has these spots all over the place on his back. That's not something I see around here very often. I think I've seen 2 cases, and people worry about it and test for it a lot around here. But a lot of it has to do with where you've been, what you've been doing. You're not going to pick it up, walking through the airport in Connecticut. You've got to be out in the woods. get exposed to these ticks. So in a sense, I call that kind of a reactive arthritis as well. That's more broad, but this person has arthritis, secondary infection in the skin, and secondarily gets arthritis in his knee. Now, rheumatic fever has been around for a long time. We don't see that often. It's a post-streptococcal group A infection followed by these manifestations. You can get a migratory arthritis. Those are the large joints. You can get valve disease and heart disease from it. That's an inflammatory process. Ultimately leads to people having, bad valves and over the time large and, dilated hearts and heart failure. I haven't seen a case of this in a long, long time. I've had a couple of young people that came through with kind of a post-streptococcal arthritis. There is a post-streptococcal arthritis without valvulitis, and I've seen a couple of those, but it's a rare disease. I see a lot of pediatric cases as well, and this is not real common, fortunately. We give everybody antibiotics for strep throat, or presumed strep throat more often probably than we need to, but you need to have a positive culture. This has a specific rash. What's interesting, it looks a little bit like the one I just showed you. And there's subcutaneous nodules often on the tendons, which look a lot like nodules in other rheumatic diseases that I see. So you have to have a number of these manifestations to prove it, the diagnosis. There's not a single blood test that tells you that's it, but you have to prove there was streptococcal infection. And usually you want a couple of those major criteria. The minor criteria are less significant. They're less specific.
I understood that they were having some reoccurring factors in people that had our age when they were younger, and they, like the polio, symptoms reoccurring, but there were some symptoms of reoccurring young. They were doing a study on it, and I had written to the CDC, and I got no response whatsoever. Who's doing the study? Where is it? What's going on?
Yeah, I don't have a lot of information off you on that. I can look into it, but I'm not. That's something I've been appraised of lately. Where did you read about that?
Doctor's office in June.
Okay, well, that's a good place to get your information.
Sorry.
That's okay.
It's been like a year and a half to 2 years
Okay.
that I've been trying to research that.
Okay. All right. Well, this is the rash, and again, it's a round, kind of serpiginous border, slightly raised, and they have a bit of central pallor as well. And it's called erythema marginatum, but the margins are a little bit raised. It's a little bit different look. But at first glance, you could say, wow, those are a bunch of those other lesions, but they're not really the same. This is a lesion close up, but there's no central tick bite. And they get these nodules. This is Achilles tendon. You can see those little bumps along the edge of that area, and then on the bottom of this foot, there's those little nodules that are not common, but do occur in this disease. So finally, what's reactive arthritis? Now this is a more restricted term, use of the term. We used to call this disease Reiter's syndrome, R-E-I-T-E-R-S syndrome. And Reiter's syndrome is a form of arthritis that becomes chronic and is associated with mucocutaneous, cutaneous, and arthritic, as well as spinal symptoms on occasion, as well as ocular symptoms. And a lot of these features look an awful lot like those things we see in psoriatic arthritis and inflammatory arthritis of the spine or spondyloarthritis. So it appears soon or after an infection somewhere in the body. And we don't use the term Reiter's syndrome anymore. It used to be arthritis, conjunctivitis, urethritis, were the three features in the triad of Reiter's syndrome. But it's really more than that. And it comes from these infections. A lot of gastrointestinal things, one of which you've probably heard about around here is salmonella, and but shigellosis, E. coli, Clostridium difficile, which is much more common these days, particularly in the antibiotic world. A lot of people are on antibiotics and they get this secondary diarrhea, and they get gastroenterologists have to give you another antibiotic to get rid of this germ. The chlamydia is part of the genitourinary tract, and there are ways to culture for that. And that's not always all that symptomatic. So, first criteria, it has to be days to weeks delay between the infection and the actual arthritis. It's most often one joint, but it can be a number of joints. Oligo means few. And it's usually in the lower limbs. And it may be associated with a fat swollen toe, we call dactylitis, inflammation of the tendon attachments like Achilles tendonitis or plantar fasciitis. That's collectively known as enthesitis. You're going to have eye involvement and skin manifestations. If that individual happens to be B27 positive and acquires one of these infections, they have a strong tendency to develop inflammatory spine disease known as ankylosing spondylitis. The percentage is about ranges from 40 to 60% of the people that are B27 positive that acquire one of these infections and this syndrome will in fact have the spinal inflammation as well. So there's a genetic predisposition to the full package, so to speak. Here's a swollen left knee. That's the only joint that was swollen in this individual with this particular condition. You can kind of see on the left that it's around the kneecap, it's kind of puffy and full there. You get this red hot toe. Now that could be a lot of different things, but when you see what we call a sausage toe, the first thing that comes to mind is psoriatic arthritis. The second thing that comes along is Reiter syndrome, and it could be gout or pseudogout. It wouldn't likely be an infection. Possible, but not very likely. But that sausage toe brings a whole, makes my little light bulb go on. I'm looking at psoriatic arthritis, and sometimes that presents before the skin disease does. They can have inflammation of the eye, the conjunctiva, which is, the pink eye under your eyelid. You can get inflammation of the anterior portion of the eye. You can see how where the iris is and the pupil is, it's kind of cloudy looking. And if you look at the bottom of the eye, there's a little layer of white cells that have settled down in front of the iris into the anterior chamber of that eye. That's called a hypopyon. That's a nice word for low, pus in the low part of the eye, basically. Yet these are characteristic lesions in the tongue. That's part of it. Not all that common, but once in a while. But it's important to look for them. They can be up on the palate like this. The patient may not even recognize they're there. Sometimes they're rather easily overlooked if you don't think about it and look for them. But they're rather sharply demarcated, and they're kind of a deep brownish red typically. This is what happens on the sole of the foot, and sometimes on the palms of the hand, but more often in the foot. And this is a interesting term, keratoderma blennoragicum. Took me quite some time to learn how to say that out loud. But it really just means it's a lot of thickening of the skin, flaking the keratosis, and it looks hemorrhagic. It's just really, really thick and very uncomfortable. And you can see it's on the tips of the toes and around the nails. And this is what happens with fingernails. And this looks a lot like psoriasis. And sometimes they're hard to differentiate. But again, these are the skin and nail manifestations of this condition. And these same sort of not so pretty red sort of things can happen on the genitalia. In a male, you get the guy thinks he's dying, of course, he's of some dread illness, and he's not. But it's unusual. I've only had a handful of these in my practice in the entire time I've listed on this planet. It's not a common disease. But it's interesting because we've learned some things about the epidemiology of these diseases, where they come from. Reiter syndrome is strongly associated with sexually active males who are homosexual, and they also frequently are HIV positive at the same time. This is a common diagnosis in San Francisco compared to Lincoln, Nebraska, for example. And this is the reactive inflammation in the sacroiliitic joint. Sacroiliitic joint is the center is the sacrum or tailbone, and off to the side of your pelvis, your hips are down here. This is the sacroiliic joint. And on that side, it's fairly clear. You can see that nice curvilinear open space. Over here, it's cloudy and blurry and becoming white. And after a while, it actually fuses. That's the same picture we see in ankylosing spondylitis, or spondylitis associated with inflammatory bowel disorders. That can occur. That can look like Crohn's disease and also colitis. And it can be seen in psoriatic arthritis as well with associated spondylitis. And the common link between all those diagnoses and the spinal inflammation is the HLA-B27 positivity. That's a test that's done on white blood cells. It's easily done. It's a tissue marker for like transplant tissue marking, and it's present in roughly 8% of the population. But not by no means does 8% of the population have this disease or any of this group of diseases. But collectively, the B27 positive diseases, when I see that little sausage toe, or I see a little bit of a nail change that looks like psoriasis, or I find a little patch of psoriasis in the scalp and they present with a swollen ankle or swollen knee, that whole spectrum of conditions comes to mind. Are we dealing with an inflammatory disease that's genetically linked to HLA-B27? So that's when we kind of think about it and check it. And in Lincoln, Nebraska, the handful of cases I've seen with this reactive arthritis have been associated with salmonellosis. One gentleman came from Firth, Nebraska. He went to a barbecue and a picnic. I'm quite sure he picked it up from the potato salad. And he had diarrhea for a while, and then later on he had this onset of joint symptoms and joint swelling. And he didn't know at the time that he had salmonella, but he remembers being sick. So I sent him to the gastroenterologist. They endoscoped him and did cultures, and lo and behold, he had salmonella. Another interesting case with a young man. He was 23, 24, just got to drinking age. He went to one of the local establishments where they were serving turkey fries, and he presents to the hospital with this red hot, swollen ankle and knee. They look infected, look like cellulitis, septic joint. Nothing grew out of the culture. Their white count within the joint fluid was quite elevated. And I said, have you been sick lately? Has anything been going on? Oh, he says, yeah, about a month ago I was sick for one day. I had a couple of rounds of diarrhea. I see, okay. And I said, you remember being anywhere where you ate something unusual right before that? So yeah, I was over at this little bar. They were serving turkey fries. So he had no symptoms. There again, I had the gastroenterologist endoscope him and take some cultures, and he had salmonella in his gastrointestinal tract. So we don't see shigellosis often in this neighborhood. That can occur. That's another form of dysentery. There's an interesting story about shigellosis and this B27 story. There was a ship in the North Sea many years ago, and there was a round of dysentery on the ship, and all these guys came down with shigellosis and diarrhea from that. And a high percentage of individuals after that developed arthritic symptoms, and that's where they tumbled to the fact that the B27 genetic code was connected with those individuals who develop arthritis having been infected with shigellosis. Those other enteric gastrointestinal infections are not common in my experience, but they're described as causes of this condition. I think most of the time these things are discovered on culture and treated early enough that it doesn't happen, fortunately. And here's one more slide, I guess. I've got this enositis issue down in this heel. You can see that bone spur. That was caused by the inflammation of this condition. And the plantar fascia was inflamed, and this bone spur showed up there. That's called a periosteal periostitis, or inflammation of the periosteum, which is the covering of the bone.